Okay, good afternoon. I think we are live and welcome to everyone from Sinai Health who's joining us this afternoon. And great to be able to talk to our colleagues on these issues. I'm Howard Ovens. I'm an emergency physician here at Sinai, and I'm tasked with being the moderator today. And we have a really outstanding panel, and we're really lucky not just to have these three colleagues working with us at Sinai and on the panel today, but providing such leadership to our institution. All three of them are leaders in their field and have also been providing a great deal of input to the Ontario provincial response. So in no particular order, our panelists today include Jennie Johnstone, who's our physician lead for infection prevention and control, and Andrew Morris, who's the director of our Antimicrobial Stewardship program, and Tony Mazzulli, who's our Microbiologist-in-Chief. And just to give the context that we find ourselves in today, Toronto and Peel were successful in getting the province to extend the stay-at-home order for another 2 weeks. Given the presence of variants of concern in our community, the high number of continued new cases which have plateaued, and the recent school opening, I think we all agree that that was a very good decision. So we have to remain vigilant. Vaccine supply finally is starting to increase this week. And so if you have not been vaccinated yet, we encourage you to register on the Sinai wait list so that you will be notified when your turn comes. And we hope after today's session, any hesitation you might feel about rolling up your sleeve will be addressed, and that you'll avail yourselves of these medical miracles when they're available to you. We mainly today are going to focus on answering your questions. We got many of them in advance, so I'm going to start with the questions that we received. But if further questions arise, if you put them in the chat box, we'll do our best to get to all of them. And we will be recording this session. So if you're not able to stay with us for the entire event, it'll be a link to it will be provided in the daily update later this week, and you can see it then. So let's begin with the first question. And again, these three people are such experts, any one of them could take all of these questions, but we're just going to divide them up for convenience. So question number one, the COVID-19 vaccines were developed very quickly, and the mRNA technology particularly is very new. How do we know for sure they're safe? Could there be long-term side effects we don't know about yet? Jennie, would you take that one?
Sure. So thanks, Howard. And so I thought it would be first most helpful to talk about what the mRNA vaccines are. There are really three pieces of that question. What is the mRNA vaccine? How did it go to market so quickly? And the third piece is what are any possible long-standing side effects? So just to make sure that everyone's on the same page with respect to what the mRNA technology actually means, I should share that this is a technology that's been studied for many, many years, mostly in the domain of cancer research, whereby they were trying to develop vaccines which would then target sort of cancer cells. This is the first time they've used it against an infection. And the way in which it works is it's almost like injecting a recipe card. So mRNA is usually the pieces in the body that tell our body what to make. And so it's a little recipe card of the spike protein, which then tricks your body into making that spike protein, which you know is on is part of the COVID virus. So it's just one piece of the COVID virus. Our body gets sort of tricked into making this little protein, which it puts on the surface of its cell. And your body recognizes the fact that they do not know that protein. And so the way it works is then your body then generates the immune response to that protein that your own body's developed after reading the transcript of that recipe card that was injected by the vaccine. Mostly, I am just so excited by the fact that we were able to manufacture this exciting technology. I think I'm thrilled that we have an effective vaccine, a highly efficacious vaccine, number one. But number two, I'm more excited about what this means for future vaccine technology for other infections, knowing that we've never had a perfect flu vaccine, for example, and other infections that have been challenging for us to develop vaccines against. So I think from just a pure scientific standpoint, I think that this sets us up well for the future for additional infections and vaccine development. The other neat thing about this is because it uses this mRNA, which is just a series of instructions, as we do see changing strains, and if we do need to manufacture or remanufacture the vaccine, it's actually relatively simple to redesign the vaccine that better adapts to a variant, should a variant emerge that we actually have to change our vaccine for. So for all those reasons, I think that this is very, very exciting. I know there's some hesitation because it came to market so quickly, but there were a number of reasons for that. The first reason is that we already had this technology that had been under development for many, many years. And then we essentially had the entire global scientists all working together with one common goal, which in my knowledge has never happened before, where you had so many smart people dedicated to working through this, and also finances. So there are many governments across the world that were putting up money and private enterprise to actually be able to work towards this common good. And then a lot of the bureaucracy, meaning not the fundamental necessary steps for approval, but the time spent sitting on someone's desk was accelerated. So not the steps, there were no steps missed. And the final point is, as a trialist, something that often happens when you start to design a trial, usually the infection or whatever you're studying goes away. So you are not able to achieve those endpoints. But because these trials took place in a number of places that proved to be huge hotspots, meaning the United States and Brazil and places in Europe, they were able to get to the endpoints very quickly. So for all these reasons, all the normal pathways that we would normally undergo in very large trials still occurred. It's just there was a number of different steps that came together to be able to move this to market quickly. So again, I want to reassure everyone there were no steps that were taken. There were no steps that were omitted. It was just a matter of expediting the process. The last part of that question was about longstanding side effects, and we can talk perhaps about some of the shorter term side effects, I think, in a future question. But with the mRNA technology, what happens is after it's in your body, it quickly gets degraded. And so it doesn't stay around. So understanding that we haven't studied this for long periods of time, because of course this is still just started in the public domain in December, there isn't a scientific basis for there to be longstanding side effects. And when we look at vaccine side effects as a general comment, there aren't usually any longstanding side effects. All the side effects that generally occur within the first 3 months, for which we've already gone past that. And now we're up to millions of people who have been vaccinated. So although in COVID, what has taught us is that, this is not a risk-free world that we're in, we are sort of forging the path as we go. However, we do have to go based on evidence and evidence-informed decisions. And for that, I can tell you, there isn't a good evidence reason why we would have longstanding side effects.
Thank you very much, Jenny. And I'll just maybe emphasize 2 points. For those who don't know endpoints of trials all that well, basically, you need about 150 or 200 people to catch COVID in your control group so that you can tell if there's any difference in the treatment group between those who got placebo. And so you need a lot of COVID around to reach that endpoint. And on the second thing, we don't know much about the long-term side effects of having the virus and the so-called long haulers. And that's really the choice you're facing is, do I want to take my chances with the virus or do I want to take my chances with the vaccine? And I think you answered that very well. Thank you. And so, Tony, there's new variants of concern around. How well do we think the current vaccines work against these major variants that have been identified?
Thank you, Howard. So just before I specifically address that, just to bring people up to date, On Friday, the Public Health Lab issued their updated report on the variants. And after testing just Friday, one day, just over 1,000 positive samples, the percentage of variance is up to about 18.1%. And just to put that in perspective, they did a similar type work just before the Christmas break. And at that time, there was essentially zero. So you can see over roughly a month and a half, under 2 months, how quickly these things are spreading through the population. So having said that, and with that as background, again, the only other piece of information is that I think people recognize there are 3 different so-called variants of interest or variants of concern, as they're referred to. There's the original one from the UK, which is often referred to as B1.1.7. The South African one, which is B351, and then there's the Brazilian one, which is referred to as P1. And each of those has a common mutation known as the 501 mutation. So it's in all of them. And then each of them has unique mutations, and that's why they're considered slightly different. But the key is that all of those mutations occur, as Jennie mentioned, in the so-called S protein or the spike protein gene. And that's the protein that is required for the virus to stick to your cells. And when you get mutations in that, you may either get 3 different outcomes. One is you get mutations that mean absolutely nothing, doesn't change the virus one bit. Secondly, you might get changes that are so deadly to the virus itself that the virus just dies and it means nothing. And then third, what we're all concerned about is, can these mutations change such that A, the virus is better able to stick to your cells and therefore better able to spread, and B, by making those mutations, all those antibodies you made either from the vaccine or from having had COVID will no longer be effective because that region has mutated. And so when you're trying to figure out, is the vaccine still going to be effective against these variants, there's 2 ways to look at it. You can study it in the laboratory, and then you can look at real life situation. In the laboratory, what they'll do, and what they've done, and there's been a number of these studies, is they'll take these variants, mix it with antibodies that people have made after getting the vaccine, and usually they wait about 2 to 4 weeks after you've had your second dose, and they see whether in fact those antibodies can neutralize the virus, meaning prevent it from infecting cells, at least in the laboratory. And to date, all the studies have suggested that they still work. Okay, so at least from a laboratory perspective, it looks like the vaccine will still be effective against the current mutant strains that are out there. The second way to look at it is in the real world, and that means everybody who's had the vaccine, what they really want to know is, am I protected or not? And that one's a little more difficult to do in a short period of time, because you have to wait for people to get exposed to these mutants and see whether in fact those who had the vaccine and those didn't, is there a difference? Up until now, it seems like there is still protection from the vaccine against these variants. The variants have not changed enough to diminish the clinical effectiveness of the vaccine. So going forward, that's great, but the virus is not static. Time will tell whether new variants come out or whether new mutations accumulate. And of course, and that's part of the reason we continue to monitor it, test for it, and look for it in the population. But at the present time, it still looks like these vaccines are effective against the 3 current mutant strains.
Thank you, Tony. Next question is for Andrew, and I'll just mention that Andrew started off at the beginning of the pandemic writing a short email every week or so to his friends and neighbors, updating them on what was happening in the pandemic. It has grown into a monster blog that he sends out every week, which is very informative and very entertaining. And if you are interested in it, you should sign up for it. And you can do so by going to covidemails.com. Did I say that right?
Yes.
Yeah, covidemails.com. So the next question for Andrew is, and I'm going to pair it with a question from the chat that's related. First part is, does delaying the second dose have an impact on vaccine efficacy? And what a related question was put in the chat is an example of a Sinai nurse who has been asked to wait for 5 weeks to get their second dose and is wondering why they were going off protocol. And I think the two are quite related. So Andrew, can you take a shot at that?
Sure. And I thought it was actually only my mother that was advertising my emails weekly, but thank you for letting people know about that. So first of all, I think anyone who's had children or know of children who get vaccinated know that as part of any kind of vaccine schedule, often there are multiple booster doses that are given. And the reason why booster doses are given is because the first vaccine dose that's given doesn't always stimulate the immune system enough to give full protection. So when we give a vaccine, as Dr. Johnstone mentioned, what it really does is it trains our immune system to be ready for the big game, right? When we really will get exposed to the virus. And so, giving a booster dose, what that does is really gives an extra priming for our immune system. Almost certainly for every kind of vaccine that people are exposed to, there's a sweet spot. I'm not a big wine drinker, but I know that, when you open a bottle, first of all, it's good for a wine bottle to age. And then even after that, many people say you need the wine to breathe, and there is a sweet spot. The sweet spot for the times that have been given for these vaccines have been scientifically estimated and then tested. And so what the scientists believe is that somewhere between 3 and 4 weeks, it varies between the two mRNA vaccines. You have an ideal time period whereby if you get a booster dose that second time, we know that the booster works and is highly effective at that time period. We wouldn't really be talking about altering that time period if we had an abundance of vaccine that we could give today. I think that's a reality that we just have to realize, that everyone in the world is scrambling to get as much vaccine as possible, and we don't have that. The decision making that the various task forces, and we have in Canada, we have the National Advisory Committee on Immunization Practices that gives us guidance, and then every province comes up with their own, I guess, adaptations of that guidance. And one of the things that was clearly identified is that, especially when there are so many people at risk for infection, we could potentially optimize that by giving people vaccine, a first dose, and getting that first dose to them as much as possible. And the thing that really struck me was, I was having a conversation with somebody, and I said, I don't want you to think about this in terms of the whole country or even the province, but I want you to think that it's your mom and dad, and you've only got 1 to 2 doses available. And are you going to give your dose, those 2 doses to mom or dad, or are you going to give each one of them 1 of those doses? And I'm not assuming anyone's relationship with their parents, if their parents are still alive, but I think most people would probably say you'd give 1 dose to mom and 1 dose to dad, and then we'll deal with what happens thereafter. I think on top of that, what we also have learned is that because it takes a while for the vaccine to take effect, is that after a couple of weeks of the vaccine taking effect, the initial first dose of the vaccine is quite highly effective, almost certainly higher than what was initially reported in the scientific papers. And so we're not talking of around 50%, but we're talking over 80% effective after the first couple of weeks for those vaccines. And I think because of that, what we're trying to do is take advantage of the fact that A, these vaccines are excellent vaccines, and B, the time is of the essence. And the more different arms we can get vaccine into at least a first dose, people will get benefit of it. The one thing that we're trying to avoid is that period of time being too long. And I think so far we're trying to avoid that. But to be honest with you, we don't know what too long is. And I will point out that with a vaccine that we haven't yet approved in Canada, and it's a totally different technology, but the Oxford AstraZeneca vaccine probably has a benefit from waiting a little bit longer. It's sort of like aging a little bit longer. That priming might be better to wait for that second dose. And we do know, for example, like for some vaccines, we do wait up to 5 months after a dose or even 6 months for another priming dose or booster dose. So I think it's really important to recognize that what we're trying to do is benefit as many people as possible, and most importantly, save lives and prevent people from getting seriously ill.
So I have a follow-up question for you, Andrew, but first, just clarify for people, when you say 50% or 80% effective, but you talk about preventing death and serious illness, can you just give us a better idea of how effective these vaccines are at preventing hospitalization and death?
Yeah, so I think we have the best example we have now. So we have certainly all the scientific papers that are available. And if you sum up all the scientific papers, if you get the vaccine and you get the full schedule, you're not going to die. You're not going to get seriously ill. Like that is, it's essentially zero. Like the likelihood of you getting seriously ill from COVID, if you get the vaccine, approaches zero. On top of that, we have this, amazing natural experiment that's been occurring in Israel, where they have been vaccinating by age primarily, and they've gone so that they have over 90% of people over age 60 now vaccinated. And the importance of new people over age 60 coming to the hospital at all for any COVID-related illness has essentially disappeared. The only time it hasn't disappeared is in that small segment of the population who hasn't or refused to get the vaccine. And to me, that is, that is a society that's now able to substantially open up. They are actively working to open up. And it's because of what I'm going to say is the pretty miraculous results of these vaccines. Like Dr. Johnstone mentioned this, but I can't emphasize enough how amazing these vaccines really are compared to, some of these other vaccines we've had over time that are really good for us, and keeping us safe, but haven't had the same results that we've seen here. These are really amazing results.
And just to address a question, a little bit of the conversation in the chat. First of all, you can't demand a specific date to receive your vaccine if the supply isn't there. We're doing the best we can for everybody. And don't forget, we're at the front of the line, primarily, not because we're so deserving, but to protect our patients. And if you have specific personal questions, you should email them to covidvaccine@sinaihealth.ca. We're not going to get into too much of the personal questions, but I think a lot of your questions will be answered by our general responses. So, a lot of the, this one's also a follow-up for Andrew. A lot of the skepticism and COVID denial comes from younger, healthier people who feel they have little risk of getting ill, and probably most of their peer group who've had COVID have done fine, and they haven't really seen what we've seen in the hospital in terms of serious illness and death. So if you're young and healthy and look after yourself, get lots of vitamin D and all that, all those good things, why, and you have a strong immune system, why should you get yourself vaccinated?
It's a great question. I think there's several parts to that. The first thing I'm going to say is that your immune system is really important, But I think it's really important to understand that sometimes having your immune system really active isn't so good with this disease in the first place. And in fact, what we've learned is that some of the people who've gotten very unwell, it's because their immune system has, in response to being infected, has, in and of itself caused damage. It's kind of collateral damage while responding to the virus. It's also caused so much inflammation that, especially the lungs, but other parts of the body throughout the body become quite unwell. So, the concept that, your immune system and that you can boost your immune system to protect you from the effects of this, I think it's not certain. For young people, I think there's a few reasons why it's really important to get vaccinated. Unfortunately, a lot of the data that everyone sees every day are around hospitalizations and deaths. And for sure, younger adults and younger people won't have nearly as much of that effect. I will point out, by the way, though, that about half of our intensive care unit beds across the country are filled with people who are, under the age of 70, and many of them are people in their 40s and 50s. We do, and the youngest I've seen, it was a 20-year-old, and younger people are certainly not immune from the effects of this disease. On top of that, I think what's really important to understand is that infectious diseases, the illnesses due to infections, include things that don't make you wind up in hospital. They don't cause you to die, but they do make you quite miserable. And they can make you miserable in ways that we don't yet fully understand. And you sort of alluded to the long haulers or people with long COVID. These are people who have been infected with COVID, have gotten over it, but once they've apparently healed, have symptoms that last for weeks, if not months. Certainly there's nobody with 5 years of symptoms of COVID because we haven't had COVID around us for that long, but we really don't know. And to me, one of the most important things or reasons not to get COVID and do everything to avoid it is because we really don't understand. The last thing I'm going to point out is that none of us live in a vacuum, and we interact with other people. And I know for myself and for others, one of the most important reasons why they should be vaccinated is it's for their loved ones who may be at risk. And because I think we want all our loved ones to be around for hopefully the next town hall, the next celebration, the next holiday, religious holiday, whatever it is. And the way to ensure that there are as many people in next year's photographs as were in last year's photographs is to make sure that we get as many people as possible vaccinated.
And from a selfish point of view, if you want to travel and go to restaurants and Raptor games, we need everybody to roll up their sleeves, right?
Absolutely. There's no question about that.
So next question is for Jennie. And the way it was articulated was, I'm now fully vaccinated. Can I go visit family members who live outside my household? And I'm going to ask you to answer that in two ways. One, what you understand of the legal response in Toronto right now, and more importantly, the medical response, because it touches on a number of other questions around post-vaccination status in terms of your risk to transmit the virus to other people and all the implications that come with that.
Thanks. So I think I'm going to touch on the medical aspect first, and then get into the public health measures. So in terms of the medical reasons, so the short answer is no, not yet, for a few different reasons. So the first reason is that we still have a lot of COVID around, lots and lots. Our rates are still extraordinarily high. And so our risk of being exposed, even when vaccinated, is still quite high. And remembering, even though the vaccine is 94 to 95% effective, it's still only 94 to 95% effective. There is still a chance that you could still get infected and transmit it. So no vaccine is perfect. And I do want to just share, and Dr. Morris did touch on this as well, these vaccines are highly efficacious. I know that we don't talk about percentage. I think the general public thinks of all vaccines as being 100% effective, but that is not true. Even our really good vaccines, which are MMR or measles, mumps, rubella, are still sort of in the high 80s, low 90s. Like this is truly revolutionized in terms of how efficacious this vaccine is, but it's still not perfect. And then we also have this added sort of variants of concern piece, which to Dr. Mazzulli's point, we believe will still be effective against the variants, but there's a little less certainty, a little less knowledge around that. So, sort of the best we're going to have is 95%, and there may be a little bit of uncertainty there. I personally believe we'll still have very effective vaccines against even the other variants of concern. However, it may not be the same amount. It may not be 94, 95%. We'll see. The second piece is something that we will have an answer to soon, which is the ability of the vaccine to protect us against asymptomatic infection. So going back to those trial endpoints that I had mentioned earlier, which is when you run a trial, what you call an outcome, what you count as an outcome in these trials was symptomatic infection. So they did not routinely swab people every week or every 2 weeks or what have you throughout the duration of the trial to know whether or not people were asymptomatically infected. They just knew that they just were able to track the people who developed symptoms and then tested positive. So there is a little bit of concern about the fact that although it may reduce symptomatic infection to almost nothing, it may not have the same effect on asymptomatic infection. There's some preliminary data now coming out of Israel which suggests what I think we all believe will happen is that it will reduce asymptomatic infection as well, but we just don't have robust data around that. So the concern is, of course, that you could be exposed, you may not know you have infection, and then if you see somebody who has no immunity, then you could theoretically transmit. Again, we will gain those data, I think probably within the next month or so, but in this moment in time, we're in a little bit of a knowledge gap. And then the third piece of it, of course, I was assuming that your loved one outside your bubble is not vaccinated. So this is the piece where we actually have to make sure we vaccinate those who are higher risk of getting infected and the elderly and then all the way down before we can start opening up. And Dr. Morris already alluded to Israel, where they're starting to see that opening up because they have, I think, over 50% of the population vaccinated now. And so as we roll through it and as we increase the percentage of the population that's vaccinated, then we can start opening up. And as we see our rates drop, because again, right now our rates are so high, our chance of being exposed are still substantial. But as that diminishes, as it goes away, then we'll be able to start to open up. And as we have the percentage of the population vaccinated, I think I saw this morning only 2.6% of the population is vaccinated right now in Canada. So it's still extraordinarily low. We are far away from anywhere close to herd immunity. And then the last piece of it, I think, is legally. So this is why it's so important, even if you're vaccinated, that you still adhere to all of those public health measures. So even if even if you said, Jennie, Johnstone, you said we could go visit our loved ones, well, in fact, you can't because we have public health measures. We are still in a stay-at-home order here down in the Toronto area in Peel. So you cannot go eat no matter what anybody says. There are still legal ramifications for contravening public health measures. So we do have these public health measures in place. I would encourage everyone to continue them. And as well, just to emphasize the point here in the hospital, we do have to continue masking, hand hygiene, physically distance for all the reasons I mentioned.
Thank you very much. Just to respond to one thing in the chat, I did not intend to suggest that young people are the only ones responsible for COVID denialism. President Trump was not a very young man, for instance. I only used a young person as an exemplar because of the question about if you're at low risk for serious COVID disease, should you still get vaccinated? So I apologize if anyone took any offense at that. So Tony, you've already explained to us a little bit about the process that leads to new variants, the random nature of mutation. Putting on your crystal ball, do you think there will be more variants of concern emerging? And if so, maybe we'll combine it with the next one. If so, do you really think that we'll ever get rid of COVID the way we did with we did with SARS? You're on mute, Tony. Thanks.
Okay, sorry about that. So in terms of mutation, just to put it in perspective for you, I think people have to understand that any living thing that replicates or multiplies and has to make copies of its genetic code will make mistakes in that replication or during that process. And so a mutation is a mistake when it's trying to make a copy of itself to make another new sort of virus, if you will. But you can look at different viruses and you can ask how quickly do those mutations occur. And for the SARS coronavirus, in the past year now, the data suggests that the virus accumulates at least 1 to 2 new mutations per month. Okay, so you can tell now over the past 12 or so many months that the virus has been around, how many mutations have occurred within the virus that are not completely lethal, but that allow it to continue to replicate. Again, just to show you an example, last March, there was an unusual mutation noted in the virus, again in this S gene or S protein region called 614. By June, so 2.5 months later, so the first mutation was detected in March. By June, every single SARS virus that circulates now contains this mutation. Nobody heard of it because it did absolutely nothing. It had no impact on how infectious, how deadly, how much it spread, but it was there. And so now it became the standard virus. Again, just as a comparison, if you look at the flu virus that we know comes every year, and we get a flu shot every year that's slightly different from the previous years, that virus makes mistakes or gets mutations about twice as much as the SARS coronavirus. So it's getting about 2 to 4 a month as opposed to 1 to 2. But we can deal with that, modifying the vaccine and implementing the same sort of control measures. So with respect to the question, will we see more variants emerging? The answer is yes. I mean, this virus is not going to stop. Mutations will continue to occur, and they're going to accumulate within that virus. Having said that, with respect to the second part of the question, will we ever get rid of SARS coronavirus? Probably not, but it'll be manageable. And as long as what's been discussed by the other speakers, enough of the population gets vaccinated, is immune, and if we have to make like a flu vaccine one every year or every season, modify it, maybe that'll be the way we manage it. But I think the virus is probably here to stay. It's well adapted to humans, and therefore it's going to continue to circulate in the population long after this year goes by and we move into the future. The original SARS didn't, because it was very localized. If people remember back in 2003, it was really a hospital or healthcare associated virus and had not managed to take hold in the population the way this one has on a world scale.
Thank you. I should know enough with this crowd to make sure I refer to SARS-1 virus and SARS-2 coronavirus. So thanks for adding that distinction. I'm going to go off script a little because I want to give priority to questions around vaccine safety, because really our most important mission today is to reassure you about the safety of the vaccine. So Andrew, could you comment on 2 things? One, safety and efficacy in autoimmune people with autoimmune diseases or immune compromised people, and perhaps carry on from there to the issue of pregnancy or planned pregnancy and the vaccine.
Sure. It's complicated to discuss those in terms of evidence, because the first trials that the vaccines were carried out in the populations didn't include everyone who you've mentioned, including pregnant women. And so that has really created a lot of challenges for advisory groups internationally. What you've seen over time, however, and I will address the pregnant women first, and then we'll move to the autoimmune, people with autoimmune disorders, is that because of how the vaccine works, and really what you're doing is allowing the human body to create that spike protein. And then the initial vaccine components really dissipate. In theory, that means that the risk to not only the pregnant person, but also the fetus that's being carried or is being conceived, that risk becomes very low. I think on top of that, and probably most important, is that unlike in the very early days where we had no idea, we've come to realize that the risk to pregnant women is higher than non-pregnant women at the same age if they were to be infected. And so when you combine with what we believe and have learned is a very safe vaccine, that on both really from everything we've experienced, in Ontario, we've had almost 500,000 people immunized, worldwide, tens of millions of people immunized. The safety is unquestionable. And when you combine that with what we know about concerns with safety and people who are pregnant or trying to conceive, they're also around many young people. That's just part of their sort of ecosystem. And it makes it very difficult for them to really isolate themselves away from the risk of getting infected. And so because of that, it makes the potential benefit and importance of the vaccine that much higher. One thing I would point out is, and I think in Canada that this has been the advice, is that women who are planning to conceive or are pregnant and are considering the vaccine, they should really have that discussion with their healthcare provider to really, assess their own personal comfort and risks around this. And so no matter what I say today, I think it's really important to be informed and really have that informed discussion so that you can, have shared decision-making around that decision. Then when we get to people with autoimmune conditions or other immunodeficiency states, which can include people undergoing cancer therapy, people who are being treated for autoimmune disorders, people, transplantation recipients, et cetera. Again, we don't have tremendous global experience from that. It's possible that they may not respond as robustly to the vaccine. That is certainly possible. But if we're thinking, what is, from a theoretical basis, what are they more likely to get harmed from? A protein component of the virus, or the whole virus if they were to get infected? And if it were me, I would much prefer to get exposed to just one protein component of the virus that I then develop an immune response to, rather than the whole virus circulating out in the community with all the badness that we've learned that it causes. So, this is a situation, once again, where I think it's really important for those people to have that discussion with their healthcare providers and have a more thorough, particular discussion with their own personal values and situations. But overall, as a principle, I think what most of the experts, including I think most of us here today, are saying is that you should feel fairly comfortable that this is a safe vaccine for a wide range of populations.
Thank you. Again, I'm going a little bit out of order to try and get the high priority questions in the time that we have left. So one of the questions, lots of our healthcare colleagues have had COVID already and recovered. So Jennie, would you comment on the immune response to the disease versus the vaccine and the implications on getting vaccinated if you know that you're a recovered COVID sufferer?
So with COVID, and people have had a history of COVID, we're pretty confident that you won't see reinfection after about 90 days, so after about 3 months. But as you go out in time, and as you have the emergence of these new variants of concern, our confidence in the ability that previous infection, especially if it was, say, a wave 1 infection, we are less confident that that's going to protect you in going into the future. And so what we hope to do with vaccination is that even if you've had COVID, that you still get vaccinated, because what we're hoping to do is have that long-lasting immunity that we're less confident with just having been COVID recovered. Certainly, there's no question that if you've had COVID, and especially if you've had COVID recently, there isn't a rush to get the vaccine. And the advice that I've been giving is that when your number's up, whenever it is, then go ahead and get vaccinated at that point in time. Of course, you want to make sure you're not acutely unwell from the infection, and you want to make sure you're through the infectivity phase. But after that, truly, you could really just get your vaccine at any point. But it is important to still get vaccinated.
And going back to the variants, an important question, Tony, are the new variants more contagious? We know some of them are. But more specifically, do they behave differently? For instance, do they live longer on surfaces? Are they airborne? Are the symptoms, the clinical syndrome, the same or different? And what does that mean for other activities that we take to protect ourselves?
Well, based on the information that's currently available, clearly, as you pointed out, the only key difference has been the infectivity or the transmissibility, if you will, of these new variants, meaning that if they get into a population or into a group or a cluster, you tend to get a much higher number of people who catch it from that initial source or that initial person. And that would make sense, because if you look at where the mutations are, they're in that spike protein, which is that protein that the virus needs to stick to your cells and then get inside your cells so it can do its damage and begin to multiply and grow. So it only makes sense that if the mutations are happening in the spike protein, you would expect it to be more infectious. What we aren't seeing are effects on either mortality or death rate from it, severity of disease. There's no reason to believe these viruses would survive any more on a surface than the original so-called wild type. The spike protein doesn't confer the ability to survive on a surface, on a clothing, on your hands. So you wouldn't expect that, and nor are anybody reporting those types of prolonged survival rates. So at the moment, unless we start to see mutations in other regions of the virus, for now, the only major difference has been its communicability or its transmissibility.
Thank you. Question about for people, maybe Andrew, you want to take this one. If you have an allergy to the flu vaccine or other allergies, apparently you can't register on the Sinai wait list. Any advice on the procedure they should follow?
Yeah, I'm not sure about the logistics of it. What we know is that people who have had prior reactions to the COVID vaccine. So if you had a bad reaction to the first one or an anaphylactic reaction to the first COVID and you're getting a second one, that's obviously a reason. There are very few components in the vaccine that people would actually knowingly have a severe allergic reaction to. The most common one that people could probably pronounce is PEG, or polyethylene glycol. I guess acetic acid is another one that's a minor component, but most of the other ones are pretty obscure chemicals that most people wouldn't have an allergic reaction to. It is a vaccine that's very dissimilar. The Pfizer and the Moderna vaccines are very dissimilar to the flu vaccine, and having an allergic reaction to one doesn't preclude you, at least as far as we know, from getting either of the COVID vaccines that are available at present.
So, and I'll remind people, if you have a personal question we haven't answered that relates to Sinai vaccination processes, you can email covidvaccine@sinaihealth.ca, and we'll get you a personal answer. So looking ahead a bit more, two linked questions for you, Jennie. What's our best guess about how many, what percentage of the population needs to be vaccinated for us to get to herd immunity? And when will we be able to take off our masks in the hospital and in the community? What has to happen for that to take place?
So in terms of herd immunity, we don't know for sure, but the best guess are around 70%. And most of the experts from around the world, which I must admit are people smarter than I, have come to that number. There is some suggestion that possibly with the variants of concern that it may be slightly higher than that, maybe up to 80%. But it's in that realm that we're going to have in terms of the percentage of the population who are vaccinated before we start to see any sort of meaningful reduction based on herd effect and sort of starting relaxing those public health measures. So remembering I mentioned it's 2.6% this morning. So we have a long, long way to go, but I think it is good news in terms of the supply chain opening up. And I think certainly here in Toronto, Ontario, and in Canada, they're starting to work towards those mass vaccination clinics, which are going to be so key to getting our population vaccinated. The question about the masking specifically, I mean, I think as we get our elderly and older population and those at risk vaccinated, certainly we'll start to be able to relax some of those public health measures. But when we're going to be able to get rid of masking altogether, I really don't know. It's curious, every pandemic there are legacy interventions that are sustained. And so I do wonder about masking in hospitals, if that will continue post-pandemic. I don't think it would ever be to the degree that we're doing now, where you have to be so vigilant, but I wonder whether we're going to get rid of it completely. I don't know. I mean, I think it's too early to have those conversations. I just am curious. And similarly in the community, again, I think that we will move towards, eliminating them, or not eliminate, reducing them. But remembering that in Asia, post-SARS-CoV-1, that in large parts of Asia, mask wearing is common practice in very public areas. And so whether or not we'll get rid of it altogether, I do not know. But I think the question really people are getting at is, when can we start to relax the public health measures? When do we not have to be vigilant all the time, 100% of the time? And really start to have, dinner parties in our homes and whatnot, and have a more normal life. And I hope that it's going to be, towards, timelines are a little bit difficult, but towards the summer, when we start to see that herd immunity and can start to relax.
Thank you. A couple of questions that are mostly for interest, but they are intellectually intriguing. And so just even a brief answer. Andrew, what do you think of the Sputnik vaccine? Is it effective?
Let me just clarify that Tony and Jennie are way more intellectual than I am. So they're always the one more likely to answer these, better suited to answer these questions. I think that the Sputnik one's very interesting, and certainly the results that they've reported are pretty promising. I think the challenge that many of us have is, we just aren't so certain of the data, right? And certainly it's an adenovirus-based vector that they've used, and that is a kind of proven means of the vaccine. Almost certainly won't be as, or it isn't as efficacious and effective as the mRNA vaccines. I don't think it will be coming to a pharmacy in Toronto soon.
And I'm not sure who would know the answer to this better, Jennie or Tony, but Jennie mentioned prior work on mRNA vaccines. And somebody asked, why have none of the prior vaccines in development, like those for the common cold or other things, ever come to market before this? Either of you want to take a swing at that?
I can take a partial sort of answer to it. I mean, in general, when you look at priorities of what people want to focus their efforts on, whether it's large pharmaceutical companies, researchers, it's trying to target illnesses or diseases, or in this case, viruses that have significant impact. And, given that colds, flus, cold illnesses are sort of relatively mild, that isn't a major priority as opposed to, say, cancer, where someone has a higher chance of, say, dying, serious illness, and so on. So efforts are targeted first to the more serious illnesses. And then, sure, if you solve all of those problems, people will start to look at some of these other viruses or other illnesses as well.
And this one we've alluded to, but it's an important one. Maybe Jennie, you'll take this one. Are certain vaccines more effective than others, which leads to the question, will we have a choice at any point in which one we take? And if so, which one should we choose?
So certainly there are vaccines that are more efficacious. And so the mRNA vaccines so far are the leaders of the pack in terms of the effectiveness and efficacious. So there are a few others coming down the pipeline. One that was already referred to, there is the Oxford AstraZeneca vaccine that has been most widely used, I'd say, in the UK, but has the benefit of being far less costly. I think I've heard it's in the order of $3 versus the mRNA, which are about $30, and don't require the complex refrigeration process. So I do think that one will have wide uptake, especially in developing countries. And I do know that Canada has purchased quite a lot of those doses. The question is, it's not yet Health Canada approved. And the question is perhaps what populations will they be used in? And so I do think, again, what I've read, I think there's some concern about its efficaciousness in the older population, although there's debate right now in the literature. But whether or not that's the one that you're going to choose for, say, your nursing home population, where you know that you need to have the best vaccine possible. So I think it's going to be more about choosing the right population and the right geographic location for some of these vaccines. And whether or not there will be choice, I have no idea. But I will say that all of the vaccines that have come to market, quite frankly, we are being spoiled with various options. I mean, I would have just been happy with one that worked. And quite frankly, if you had have asked me in October, I would have been happy with one that was 70% effective. And truly one that, as long as it prevents severe disease, we can all tolerate colds. We're never going to get rid of rhinovirus and all the other viruses that circulate. So that's not the goal. The goal is preventing severe outcomes, so hospitalization and deaths, and certainly widespread. So, I'd say all of the vaccines have very good safety profiles and work well. Again, the leaders of the pack so far are the mRNA, but whether or not a difference of 87% versus 94% meaningfully matters in a 20-year-old, I don't know. And so I think that's where our colleagues at the National Advisory Committee on Immunization are taking a look at all the vaccines coming down the pipeline and will make those recommendations about the right vaccine for the right population and the right location.
So thank you for that. We're just about out of time. I'm going to wrap up by saying that first of all, thanks very much to all of you for joining us and for all of your work during the pandemic on behalf of Sinai, and to our panel members for everything they do, for taking the time today and everything they do for Sinai and also for our community. If you have lingering doubts about the vaccine, I encourage you to ask questions and seek out more information. And again, one source for that is COVID vaccine at sinaihealth.ca. And the other thing is, the people who know the most about the vaccine and the risk benefit, who know the most about the illness, our infectious disease colleagues, our critical care colleagues who care for these patients when they're very ill, general internal medicine people on the COVID floor, and even the emergency staff really were very delighted to roll up their sleeves. And I know I took my turn without hesitation, and it's now 2 months since my first dose. I never felt better. And speak to your colleagues, but look to the experts. And we've all put our arms where our mouths are and taken the vaccine when our turn came with delight. So we hope you'll join us and protect yourself from this nasty virus and help us get out of this horrible pandemic and on to a better life ahead, thanks to science and everybody's efforts. And so on behalf of Sinai Health and my other panel members, thanks so much for taking your time out today to join us.